So I'd like to introduce back there is Carrie Stevenson.
Hi there, good morning.
Who is the kind of their stroke coordinator at Virginia Mason, and he's been my counterpoint to get this going. And this is Dr. James Bartscher, neurologist, who some of you have talked to before and others haven't. So I'm going to turn it over to him.
Well, thanks for having me today. I'm here basically to answer your questions. I think the goal really is to basically give a little overview for those of you who haven't been in our prior meetings in terms of why telestroke, why are we doing this, just to set the stage. I'll go through those slides real quickly. Try to present some frequently asked questions and stimulate any kind of other questions that you want to ask me right off the bat, and then turn it over to Linda, who can Linda Carey can tell you about the recent event that you guys had here to try to streamline your own process for your own ED. And then at the end, we'll try to do a little simulation. So we can actually use the equipment and can see it in action with the simulated case. And if one of y'all want to jump in and be the doc or the facilitator, that would be excellent. But we'll make it work with whoever we have available, okay? So really, I'm here for you. We're excited about this work. Telestroke is something that I've done since I started my neurology training back in Boston, and I think it's a really excellent way to bring the patient and specialists together as soon as possible, support the team who's caring for the patient regardless of location, and we're really excited to continue the work that we've been doing with you over the last several years to kind of take it to the next level. So if you can go to the next slide. We always just start our talks at Virginia Mason by looking at the strategic plan, and all I really wanted to mention was that with telestroke, it really is about keeping the patient at the top of the pyramid. It's trying to get them the care they need regardless of their location, for the purposes of speed and quality, giving them good service. Okay, so next slide. So telestroke, just so we all know what I'm talking about in terms of lingo, is really just another specific version of telehealth or telemedicine. Okay, just using telecommunications to bring stroke care to the acutely injured neurologic patient. This is just old screenshots from one of the early papers that showed its use and proved that it helped to improve care and increase the amount of IVTPA that was appropriately given. And there are a lot of different ways that it's been implemented, but the most common one is kind of a spoken hub model, where initially mainly larger university centers with a higher concentration of experts would be available to surrounding smaller hospitals who found it difficult to employ 24/7 coverage for acute specialty care and thus extended service. So we're just talking about telestroke here today. Okay. And telemedicine, there are a lot of reasons I think why it's appealing as the next generation of medicine in multiple areas. We're still learning how to use it in a lot of areas, but stroke is kind of one of the leaders. And in general, what it helps to do is create higher quality of care, a better patient experience, and also potentially make some gains in terms of efficiency and cost savings for the participants involved. For telestroke specifically, what we're trying to do always is kind of shift that treatment to earlier time course, because we know time is brain, and if we can treat people earlier, then their odds ratio of better outcomes is improved. So even with telephone, clearly we currently operate not in the ship and drip kind of old model, if you will, but the drip and then ship, to treat them and then get them if they need to get to a higher area for their care. We can do that via telephone, but there still may be some additional advantages to using telemedicine for that initial consultation. We'll talk about that in the next slide. This is a randomized trial that was done in Arizona with 2 hospitals, one hospital system that was rolling out telestroke, and they randomized the spokes that were coming on in the telemedicine arm versus those that were still using the older telephone model. And they tried to see with the TPA administration any difference, and was the bleed rate any different, and then also they tried to post hoc have
Judy Lionstall 435, Judy 435.
A board of experts review the cases and try to decide if it was appropriate IVTPA decision making. And you see they were doing fairly well by telephone. They were giving IVTPA what was felt to be appropriate 83% of the time. They were using it 24% of the time, which is actually very high compared to a standard, the national average for sure. But stroke centers usually 10 or 20%. And their hemorrhage rate was low. This is about the same percentage as the initial NINDS study, 6%. But when they compared that against telemedicine, they did see a slight increase in TPA use, although not statistically significant. The correct IV-TPA decision-making was statistically significant, odds ratio of 4.2, and the post-TPA ICH rate was about the same. Okay. It was a small study. It wasn't powered to look at absolute differences in outcomes, so you saw that there was no difference in the overall outcome in terms of modified ranking or so forth. But it wasn't powered to look at that. But it did seem to improve the amount of TPA given, or increase the amount of TPA given, and that it was given appropriately. That was the take home. That's the only real study of its kind, which is why I bring it out. The other thing we know about our region is that we're very dispersed. We have a lot of rural areas, as you know, and even frontier areas compared to the rest of the U.S. And it's hard to get specialty care everywhere simultaneously, especially when it's very acutely needed, like in stroke. So we have a specific, and even higher than in other parts of the U.S., opportunity to act via these newer technological means to bring the care to the patient instead of always making the patient travel for their care. Okay. And this is just one example of one program that started very early and grew very slowly in kind of an academic fashion. But you can see how, with the implementation of a telestroke system at a hub with multiple spokes expanding from only 1 to over 30, that with time, not only do you have increased teleconsultations, but you treat more patients. So that's the opportunity. The other thing is the telemedicine revolution has been going on, as you can see, for the last couple of decades, and we're really kind of in the middle of it taking off. It's not a new thing anymore. If you go to the next little, kids and our grandkids all expect to be able to Skype with us all the time, and be sure that they're going to expect the opportunity to interact with any of their caregivers, any of their service providers in and outside of medicine via virtual means. And so there's an increased demand. There's a more cost-effective solutions available, and it's more it's less scary to us and to the general public. And so all of these things converge. You can click forward one more time on us adopting it, and we're right in the middle, I think, of the adoption. There's still some opportunity for growth, but that's not going to be around forever. We need to get moving. Stroke has been around longer than some applications of telemedicine, which are just getting started, like in primary care. And this is a relatively well-proven ground that we're embarking on as our first exploration of this together in our partnership. So, but continue to think of how else as you get familiar with this technology, how else you could potentially think about using it and where we could grow from here, because I think the sky's the limit in a lot of ways. You just need to know the limits of the technology, and what you're really trying to do is just deliver the same excellent care you deliver every day. Just how can you do it even faster and even more broadly? When we embarked on this journey, I don't want you to read this, but we tried to think ahead of time what are some of the key attributes for the technology that are going to make it sustainable. One is ease of use. One was specific things about the functionality. We wanted to be very reliable and secure, and to have the potential to expand and grow as the need for growth continued over time. And so we wanted to choose our technologies wisely to give us the flexibility, but also the security that we needed. And so if you go to the next slide, the trio of software that we're using right now includes the telemedicine software called Video, one of the strengths of which is that it automatically scales up and scales down the video and audio quality that it's trying to send across a network based on the changing network conditions. So if I'm on a wireless signal out in the community versus a wired broadband signal at the hospital, it's not going to try to send the same amount of packets per second in those two situations. It's going to monitor for and change what it's sending to try to minimize the amount of choppiness and to maximize the video quality and smoothness. And that's one of the few vendors right now in the market that does that. So, and it's all internet-based, so it's device or platform agnostic, so you can use it on almost any device, which we thought was good in terms of meeting our quality goals and also our flexibility goals. It's all all this is securely hosted behind a firewall that meets HIPAA compliance by a third party that we contract with, following Mass General's lead. We've been our partners in this. And then we have our normal video imaging software that we use that's at VM. And from a hospital like yours, the images are transferred PACS to PACS to our imaging facility, and then we're able to bring them up by VPNing into our normal imaging viewing software. So again, device agnostic, uses a Citrix platform and it's behind a firewall. And then we have a documentation and kind of decision support system that was developed in a stroke center that we use as well. So we use these three things simultaneously that affect the console. Right? So frequently asked questions I'm kind of anticipating that a lot of you have, but I want you to take to the next level. Okay, we tried, as I mentioned, to choose devices and platforms that are secure. They all meet all the HIPAA requirements that we need to, and reliable and easy to use, right? So that we wanted something that was as close to one touch as possible, especially on the user end in the ED. That's really going to work every time. Doesn't need a lot of passwording or keystroking or anything like that, but when you're ready to use it, it's going to be on and it's going to work for you, because you want to be able to focus on the patient care, just like as if you were calling a consult and the person was walking into the room. You want it to be that easy. And similarly on the doc side, as easy as possible. How do I initiate a consult? So the point here is that it should be the same workflow at the beginning that you're used to. It all starts with a telephone call. We don't anticipate in this moment that we're going to have a person always sitting by a computer screen all the time. You can just dial into the computer as the first contact. So we still imagine, and most hub and spoke systems work this way, that the initial consult happens via a page out to the person on call and a telephone call back. Not only because that's reliable and probably the most efficient way, but also because that allows for an initial contact, doc to doc or provider to provider, to then decide whether a telestroke consultation is appropriate. Because not every consult that you might want to talk about, not every patient that you see and might need some assistance with may need a full televideo consultation in an urgent way. And so what we want to do is try to triage that together. Do these people meet the criteria? Is that going to be value added to this conversation, to this patient evaluation, or are we good with just talking about it on the phone? One thing a lot of folks have concerns about will telestroke slow down my workflow? We're pretty efficient, we're pretty used to what we're doing. If we throw this additional technology in the mix, are we going to actually do ourselves a disservice in a way by taking time away from other patients and or slowing down the consultation of this patient with the same outcome as we would have had initially? But certainly that's a possibility, especially when you're first onboarding with any kind of new technology. There's going to be some kind of a learning curve. Again, we tried to make things as simple as possible, and we're trying to work with you guys to create process flows ahead of time so that there's a standard process that can be as quick as possible. I think in our own ED's experience, drilling on this regularly, we've seen a marked increase in speed and comfort from the user perspective, and Carrie can comment on that later as well. But ultimately, it's also about choosing the right cases, as I just mentioned. You don't necessarily want to do this on every patient, and when things are really straightforward, nor should it slow down your care, I would say. So just because you have the opportunity to have that teleconsultation and that additional kind of specialist examination prior to transfer or prior to treatment doesn't necessarily mean that you have to slow down the treatment that you would already be initiating anyway. This is a slam dunk case, and this person was just seen 30 minutes ago downstairs, and now they're back from CT with no bleed and their pressure's normal, and they have every stroke risk factor in the book. You should be mixing that TPA, even if they're not telestroked in, But there are additional opportunities for that examination, I think, that are potentially advantageous for the patient's perspective, for the family's perspective, in terms of the experience of transferring to a tertiary center in a different location that can, in the past, when I've talked to patients and families, are meaningful to them. But again, it's a case-by-case thing, and we're here really to help you and to serve you and to serve your patients. So that I don't think there needs to be a feeling, and certainly we don't want to create a feeling in your mind that we're doing things to slow you down or make you more inefficient. We're trying to add to the service and kind of raise it to the next level in terms of complexity. In terms of who needs to be in the room, to do this job as a neurologist, all I need is one person. Sometimes I don't need anybody. I can interact directly with the patient and get almost everything I need directly from them. usually to complete the stroke scale, I'm going to need somebody to do a couple of things. When I do visual fields, when I do sensation testing, when I do neglect and so forth, it helps to have somebody in the room to use their hands, to be my hands for me, okay, to do specific components of the exam. But otherwise, my goal, as soon as I start that consultation, always is to imagine myself in the room with the patient, address them just as I would as if I was in the room with them, and carry out my examinations the same way as well. That's what I'm trying to do. So I need really one facilitator. Now that's not to say other people aren't welcome, they of course are. And one thing that came up with our ED docs when we started was, if we're especially going to talk about consent, maybe I really want to be there and be part of that process, especially if I'm going to be the one ordering the IVTPA. I don't want to be out of the room when you're discussing all this and then put my name at the bottom of the chart as the guy ordering it. I wasn't there to be part of the conversation. And that's totally understandable and fine. But by the same token, the realities of the ED we all know, and if you have multiple patients and you're called out of the room to deal with somebody else, there's no need a priori for the ED&D to be there throughout the initial evaluation, because we can circle back even by telephone, either on Telestroke or by telephone after that initial consultation and say, here's what I found, here's what I'm thinking, here's my recommendations, what do you want to do? And go from there. So there's that flexibility. All that really needs to happen is that you need one person to facilitate the exam, and if the patient's family's there, so much the better. And then the last thing that comes up a lot is it difficult for patients and families, by which I mean, what is their experience of this sort of thing? Are they going to be freaked out? Are they going to have difficulty kind of interacting with a person on a television screen? Is it generational? Is it cultural? All those things are possible, certainly. It's been my experience that it's not an issue to the degree that we expect it to be, and especially now as people become more and more tech savvy and are used to interacting with screens in this way, or a greater percent of the population is. Even those that aren't do fairly well, especially with that facilitator there as a bridge. And it really helps a lot of times for the family, has been my experience in terms of being able to tell that story, get that collateral history, and to talk about the process of transfer if indeed transfer is planned. What other burning questions to this very rudimentary list bring up from you guys that you want to throw out? Go ahead. Want to jump in? Yeah, good. I love it.
How have you worked in interpreters into the mix?
Yes, another layer of complexity. I mean, just like you would, again, my idea is, in general, towards these consultations, is you try to treat it just as if you're in the room. So whatever interpreter translation services that are available, you try to use the same way. If you've got a phone interpreter and a telestroke machine, it obviously gets very challenging.
Yeah. But a live interpreter would work well.
Yeah, it should work fine. In fact, that's what I view a lot of. That's very similar or analogous to the process of examining a stroke patient in general, because a lot of them can't talk to you directly anyway. And you're often dependent on others to help you with the exam or to obtain the history, which is a kind of translation in and of itself. But that's a good question. Sometimes also physical space becomes an issue in an ED room if you've got a lot of people or additional folks. So
have you got data about the added expense to the process for the patient or the family or whoever?
I don't. That is an excellent question. I would say that in general, for the majority of the telestroke that happens in the U.S. right now, most of it's not reimbursable. And so the amount of additional costs that it's generating for insurance companies and patients probably is much less than the actual service that's being provided.
To that? Because we're critical access, we're going to charge $44 for a facility fee, and theirs is 100% reimbursable because we are critical access. So the fee that the patient gets from the neurologist, from Virginia Mason, whatever, is 100% reimbursable. We checked into that before we started this.
Right. Because they're, Ellensburg, your facility meets whatever rurality kind of quotient was developed when this was first approved as kind of a pilot program by CMS for Medicare and Medicaid back about 10-15 years ago. It is now the case that many states have passed legislation that make these consultations, not just stroke, but telemedicine in general, reimbursable at an equal level to a face-to-face consultation that does the kind of covers the same areas and has all the same components. That similar legislation was proposed and made it through one of the bodies of legislature in Washington last year, but did not make it through the second. Did not pass the Senate. So for right now, we are not one of those states that is in that situation. But I think that the trend is certainly that's coming in the future, because even the insurance companies, I think, have started to see that potential value in kind of bringing the specialist to the patient. Okay, we'll keep going, but stop me anytime if other questions come up. So a typical consult, vascular path like this 76-year-old brought into the ED, found on the couch with new right-sided weakness and speech difficulty. Last seen prior to the nap about 2 hours ago. History of, vascular risk factors with a relatively elevated blood pressure, but a normal finger stick and a stroke scale of 18 is going to CT. What would happen next if we were thinking about, okay, this person looks like they're within the time window, they've got a big stroke, their vascular path with AFib. I didn't tell you if they were on Coumadin or not, which might be an important detail that you want to know. But what would happen next? This is not too early to get the CT to call, from my perspective. If you have a very high suspicion of the patient's within the window, that first phone call can come. I don't know if you discussed that in your protocol, but from my perspective, certainly as a treatment doc, I know we're going to have a couple-minute conversation or 30-second conversation, and we're going to hang up and we're going to decide either to follow up again by phone or follow up by telestroke immediately. It's going to take me a couple minutes, depending on where I am, if I'm at a restaurant or if I'm at home or if I'm in flow in the hospital, to get out of flow to a quiet place and open up a computer and start the program. So if we're going to do it and the CT is not done yet, that's okay. If it turns out to be a hemorrhage instead, that's okay. We can always, abort and or continue on an ad hoc basis in terms of our decision to go forward with the telemedicine portion of the consult. But we'd always rather call earlier, because time is brain, and if we're going to do this, let's do it as quick as we can. And again, we don't want to slow down the process. That's the last thing we want to do. So still page first, still call by phone, and then really joint decision making at that point in terms of triage and what needs to happen as a next step. Does that all make sense?
So one question I have about the whole idea is, how do you know you're not dealing with a TIA versus a stroke?
Okay.
You see nothing on the CAT scan. Are we going to be TPAing people with TIAs? Is it based on severity?
So when you say TIA, tell me what the definition of TIA is.
Something that goes away within 24 hours.
Okay. So that's certainly the old definition of TIA, is that 24-hour time mark. I think if you look at the newer definition that AHA put out, the American Stroke Association put out in 2012, what they're really trying to do now, we have MRI imaging, is make the distinction on the tissue level rather than on the time level. So if there's infarct, even if the symptoms go away, in 1 hour, then that's a stroke. And if there's no symptom resolution, then it's definitely a stroke. If there's symptom resolution and no infarct on imaging, then that's a TIA. So the question is, how do you know you're not giving TPA to somebody who's getting better?
Yeah.
So one of the relative contraindications of warning we know of TPA is rapid improvement in symptoms. So that's a reason why you might choose not to give it if they're already in the time window. But we also know from smaller studies that have been published since the initial TPA studies that giving TPA to mimics and giving TPA to people with low stroke scales is relatively safe. And probably safer than the whole stroke population in general, because most of the hemorrhagic conversion of the brain bleeds that we see, and we saw in that initial trial, happened in patients with big strokes, with a lot of tissue damage already. So if your stroke is size is either small or non-existent, your risk from TPA should also be lower. So in general, the way that I think about that question when I'm dealing with a patient is, okay, the symptoms are rapidly improving. Do we know the vessel situation? Do we know the anatomy? Because that can happen for a number of reasons. Either there was a clot and it dissolved, or they've got a fixed lesion somewhere or a tight stenosis somewhere in the carotid or an intracranial vessel, and they just raised their blood pressure and are perfusing around it. Therefore, their symptoms have improved, but the situation hasn't improved, and they're still at very high risk later on after we admit them to the hospital and they go to sleep and their blood pressure goes down 20 minutes for having that stroke anyway. So if we just know the CAT scan, we don't necessarily know the answer to that. And And this is the time window that we have the opportunity to give the TPA. So if they're within the window and they're getting better, and then one other thing is, what is the overall deficit and how debilitating would it be for that person if it were to come back and be fixed? Okay, and that may not be the same answer for everyone. Because the stroke scale of 2, that's aphasia in a novelist may be a lot different than a stroke scale of 2 that's numbness in the arm and leg in a 95-year-old wheelchair-bound, demented patient. So it's a little bit, I try to think about the individual situations and take into account all the guidelines and the relative contraindications in terms of the warnings and the overall stroke scale and so forth. But to think about it anatomically and to think about it in terms of disability to that patient before you kind of plug it into the risk-benefit calculation.
So you're not using MRI for that?
No, we really just want to use CT. That's because of speed and because that's how all these studies were validated. We're really trying to make that initial TPA decision anyway just based on CT. That's what we should be able to do. But I mentioned the anatomy because if you're on the fence about something, and this is sometimes where consultation can be really useful, and we're early in the window and they're getting better, it may be reasonable to say, can we just throw them in the CTA and look at those vessels? And then if they're totally open, the likelihood that this is going to come back is very low. Maybe a vacuum can stutter. It can come back either way. But you may be in a different situation than, your symptoms got all better, but I see that you've got a carotid stenosis of 99%. When you're in this window, and it's very likely that it could be worse. You can certainly keep the TPA.
So, okay, I'm on the ER side of it, and in this ER, and we have to slow them down to get rhythm and blood pressure because the system is set up that they go right for CT. But I can't even conceive of calling anybody, at Virginia Mason saying, hey, we're sending them to a CT for a possible CVA. Because when they get back, things can be different. Of course, there's hemorrhage or rapid improvement. Maybe I call them and say, hey, we're not going to drip this guy because he's, rapidly improving. But we'd like to send him to you, for other reasons. We might call them. But I'm hearing you say you want a quick heads up as we're sending them down to CT. But that's not what I do right now.
I'm saying that's your call, but from my perspective as a stroke doc, it's never too early. I'd rather be overcalled than undercalled. And I'd rather be called early for a patient who turns out not to have a stroke or turns out to get better than a system where everybody has to have, a CT and a full stroke scale and their platelets and INR back and all that kind of stuff, and then we call. We want to support your current process, and what I don't want is to have a process where you only call if a bunch of criteria are met, and then you don't give TPA until we do the Telestroke exam, it ends up actually slowing down the care. That's what I wouldn't want to see. But ultimately, we want to support your process, and you have to make the judgment call about when's right to call. I'm just trying to give you permission to call as early as you might. Just because the way it would work, as an analogy, in our hospital, with our docs right now, we also have a system that's really predisposed to getting that CT early. And they're really good at throwing them in early. And so basically, the patient would roll in, get a quick weighted finger stick, not even an IV sometimes, and the doc will do a very rudimentary exam, not a full NIHS, a very rudimentary exam, and then they'll go to CT, and if they see that, they've got the history from the ambulance that the person was normal an hour ago, and they've clearly got aphasia and right hip paralysis, they're calling me that, or they're starting the acute stroke process right then, and we don't even have the CT back, so that's, I think, I want to envision for you guys a process that's just the same as what I would do in my own hospital, and then kind of mold it to your process in whatever way it makes the most sense, and individualize it to the particular patient.
The other part of it here is that, I look at the CT, I feel fairly comfortable, but, gray, white, effacement, you're not going to get, bright white, maybe I'll get, evidence of a completed stroke, I'll get that. But maybe, there's stuff that a radiologist is going to get, but he's going to give me a fax or a call in about 30 minutes, and that's just, I just don't wait for that,
Thank goodness, right?
Yeah.
And if you tell me, I can also have that image very quickly because you guys are pushing them over to us simultaneously to when they're being pushed to the radiologist. And in these same Arizona trials, when they looked at the stroke neurologist read compared to the radiologist read, there was no statistical significant difference in looking for stroke and hemorrhage, so early stroke and early hemorrhage signs. There was a slight improvement when it was read by a neuroradiologist over a stroke neurologist, but a very small statistical difference there. But a general radiologist compared to a stroke neurologist, it was about equal in terms of picking up the cardinal signs that you'd be concerned about most of these patients. So that's another thing that hopefully we can potentially provide for you, is kind of eyes on and a quicker response to the more subtle signs of potential stroke, or at least just another set of eyes. I hear what you're saying, for sure. Okay. Other thoughts? Issues that bring you? Okay. We're done with time. So let's go to the next slide. So I just wanted to make it real simple from my perspective, but really the only two criteria that I think about in general for Telestroke is that you suspect they're having an acute ischemic stroke and they're a candidate for treatment. And in general, there's 3-hour and 4.5-hour time windows for IV. Most intra-arterial is less than 6 hours until the procedure or the decision to go to the procedure starts, which is a different situation for you guys here, obviously, because there's a transport time of 2 hours, right? And then just to make the point that sometimes in the basilar circulation, because that's usually a life-ending stroke as the basilar goes down, we do intervene later because we've seen good outcomes in a handful of folks, even if they've had symptoms for a longer period of time. But can this technology be used in other situations? Certainly can. There's no reason a priori why you couldn't use the telemedicine technology to support clinical decision-making outside of this situation. This is just the primary reason that we're in this work together. And so I think it's important to define that. I think you guys have done that in the event, and you'll hear a little bit about that. But I also just wanted to go through a couple of additional situations, if you can go to the next slide, and ask you guys, Telestroke, yes or no, think through it. This is the gray area. Can we be helpful to you or not? So a pretty straightforward one, an 83-year-old with left MCA syndrome an hour and a half ago. If you don't know anything else about the patient, that clearly sounds like a potential treatment candidate. On the other hand, a 95-year-old vasculopath brought in after waking up with new right hemiparesis, unclear when they were last seen well, so a wake-up stroke, you don't yet know, if they were up in the middle of the night normal or not. That's a harder situation, right? They don't technically, probably based on that data, meet the criteria. Yet, maybe a family member straggling in 10 minutes later and said, oh, actually, I just left and missed EMS, but they were normal 10 minutes before I called. And you just don't have that history yet. So, a gray area. But based on that criteria, you wouldn't meet kind of an acute thrombectomy candidate based on what we knew so far at that time period. What about this situation? A younger person, polysubstance abuser, presents with headache, left face arm weakness 35 minutes ago, currently they're in CT. Does that sound like that would meet criteria? What do you guys think? There's no right answers, just shout something. I see some nodding heads over there. Total silence from this side.
So go ahead.
Good. What does that make you think of, though, guys, clinically?
Cocaine.
So what do you think? What is the CT more likely to show in that situation?
Nothing.
Stroke or a bleed?
Bleed.
Probably a bleed, right? If you had to guess, you'd probably say bleed. Headache, cocaine, polysubstance abuse, but it could be a stroke, right? So that might be one case where you wait for the CT and then call. But
If you had, in that scenario, if let's say it got a little more clear cut, not just polysubstance, but they took some cocaine, okay, and then stroked out, and their CT is normal, and it's felt that there was some thrombotic event, blocking norepi platelet aggregation, so they stroked out from an embolism clot. Would you give them TPA?
yeah, we could certainly consider it. Yeah, absolutely. Yeah. That's just one of those gray areas. It's one of those warnings. Think about other potential etiologies like vasospasm, and we know that with vasculopathy there is the other tendency towards bleeding, so you certainly think twice about it. But again, if it's 35 minutes from onset, that might be another case where you do quick CTA. If you're on the fence about risk benefit, you see, we just see really, really abnormal vessels on a lot of vasospasm, in which case maybe there's not as much of a argument clinically or physiologically for TPA, or do I see beautiful vessels with one left MCA that's just cut off, like clot sitting there, in which case you have a better physiological thing. Again, there's no literature to support doing that. I'm just saying that's the way I approach it. Try to approach it physiologically and based on the anatomy when you're in those gray zones. Because otherwise, with the data that's out there, you can treat a subset of patients completely differently based on how you read the research. You can say, I'm a very conservative person. I'm only going to treat the people that have no warnings, no contraindications, everything's perfect. Those are the people I'm going to treat. Or there's centers where they say, unless they have at least 3 things, my reading of the literature, this is a pretty safe drug and I'm going to give it to people. And there's everything in between. So you have to kind of have your own rationale for how you approach it. And that's what I view our service and our job is for you guys, is to say, as specialists, here's how we think about it. This would be our recommendation, but they're under your care. And try to make you feel more comfortable if it's something that you wouldn't normally do, that we're at least there to back you up, or at least we can have that conversation so that we can offer to the patients, the most patients who could potentially appropriately benefit. That's the idea. What about this one? 44, hypertension, smoking, depression, presents with dizziness, gait instability, all over weakness, onset 2 hours ago, family reunion.
No.
Oh, and I mean, it certainly makes you think of what?
He needs oxygen.
What's that?
Psych.
Yeah, like psychogenesis,
Right.
functional disease,
Especially
it's on the
family
differential. It
reunion.
could be real.
Right.
Right. I was trying to get you that way.
Alcohol-related incident.
But the other thing is there's really good data that shows that people with functional disease, people with who have stroke mimics, don't bleed. It's a very safe drug to give to them. So she is within 2 hours, and it wouldn't be inappropriate to call a telestroke consult on this patient, even if you have a low clinical suspicion, especially if it would be helpful to the team to have a neurologist do an exam and try to see if there's some of those hallmarks to back you up, those kind of hallmarks of functional disease, give it a weakness and that kind of thing. And then lastly, just to push another kind of situation to a dramatic degree, 75-year-old metastatic CA, advanced dementia, lives in a nursing home, had a witness fall from the chair, comes in with a complete right MCA syndrome, CT already has a 90 cc hemorrhage with an ventricular extension. Telestroke for that. Doesn't sound like it, right? Doesn't sound. What I would say, you I'm sure have seen patients like this who the family comes in and they want everything done. They want to, that there's a neurosurgical intervention that could happen here. We could put it in a ventric in the guy's head. And I have used this technology in the past to have specialists to family conversations to back up a BP physician when the overall recommendation is maybe not escalating, not leaving your hometown in a situation where it's unlikely that anything is going to be done for the patient differently. So I just put that in your mind as a way that this can potentially be used. Somehow that face-to-face can sometimes be helpful. Again, that's not what we're aiming to do, that's not what we're rolling this out to do, but I've seen it used that way and it can be actually very helpful sometimes. You guys all know this picture, and if you know this picture, I find it helpful. But this is a picture that's developed by Jeff Saber's group at UCLA that I like to use with families a lot, or at least have as an option. And what it does is just tries to visualize the initial NIHS study data. So if this is 100 patients who all have equal signs and symptoms of a stroke and will meet those criteria of being treated with IVTPA within the 3-hour window, the majority of them you can see it wouldn't change their overall outcome. That they would have the same outcome that they would have had if they did not get the TPA. That's all the clear forms. 32% of them would be better than if they had gotten the TPA, and about 13% would be back to normal. On the other hand, 6, these black lines here, 6 would have had bleeding. Of those 6, 3 would be worse off because of the bleeding, and 1 would be dead. So 1 out of 100 chance of dying, 3 out of 100 chance of getting worse because of bleeding, 6% chance of bleeding, kind of a 30% chance or so of getting better. That's a way to visualize that sometimes is helpful for patients and families, and it's easily accessible. Okay? Good. I need to stop talking. I think there's only like one other slide, which just reinforces that this is a team project. We really appreciate all of you guys and your team here has been kind of getting this ready to go, and we hope that we can make some additional strides in terms of helping you guys and your patients. That's what it's all about. So let us know how we can do better. And then I was going to turn it over to Linda. She could tell you a little bit about the event that went on recently, unless you guys have any other questions for me. And we're going to do a simulation at the very end. Okay.
So last week, we had a event where we actually simulated patients. We took our whole scope of service, and I appreciate all the family practice and the docs that actually admit patients on the floor, because we actually did call at least 6 stroke alerts from the floor, not just the ER. We had 139, I think, strokes through the ER, but we did have 6 from the floor, at least. So we appreciate all of you coming because, number one, we're training nursing in the hospitals to recognize changes in their NIH and in their symptoms, but it's going to be dependent on the docs to immediately get a CT order in. So that's the biggest reason that we wanted all the docs to get trained, anybody that admits, because we want to be able to use the telestroke, we want to be able to use our stroke protocols, but the main thing is, first of all, nursing can't do orders. So we're dependent on you guys to, even if you don't have your whole stroke order set in, at least we can get the CT order in, right, immediately. As soon as the patient, we call a stroke alert. At the event, we had nurses from the floor, from ED, we had quality, we had people from all over the hospital. Dr. Frick came for a while, and we defined our stroke. It's always been kind of up to whoever to call a stroke alert or not a stroke alert. And the definition now is any stroke symptoms less than 6 hours, you go down one of 2 paths. So we're going to go, we're going to do the 6 hours. So if it's less than 3 hours until we prove that they are a hemorrhage or they're on Coumadin and they're not a lytic candidate, we're still going to call it acute stroke lytic candidate until the doctor says no, they're not a lytic candidate. Or we're going to go that 3 to 6 hours, they're still an acute stroke, but they're not a lytic candidate. So the order sets are a little different, whether it be on the floor or in the ED. The order sets are a little different depending on which path you're going to go down. So one of the things that we did was come up with notebooks. We used to have packets everywhere with stuff in it, but we kind of put this little visual thing on it so that you can see, we called the stroke alert, whether it be from the ambulance, and typically from the ambulance they already have a blood pressure, they already have a finger stick, and that's when we've been going straight to CT. And then if the patient is coming from home and shows up at the front desk, then we take them into a room, we get them on the monitor, or if they're on the floor, they've already got a blood pressure, they've already got a finger stick. So these notebooks will be around they're going to be in all 5 of the rooms 1 through 5 in the ED. There'll be one on the stroke cart, and there will also be one in CCU and one on med-surg. With Virginia Mason's help, we have devised a all stroke patients list. So this is just a checklist as to the things that need to happen with all stroke patients. And then if they are a lytic candidate, then they go down this pathway of things prior to TPA and that type of thing. Because we want to minimize any kind of sticks or anything after the TPA. This then has on the back, it has their 24-hour vital signs. So this will follow the patient. If the patient goes to VM or to Harborview, this will follow the patient. And we're getting it barcoded so that it can legally be put into the patient's chart. So this is the checklist. NPO sign, we're going pink for the entire hospital for stroke. So the NPO signs are all going to be in pink. They're NIH, and what Dr. Bartscher was talking about doing, maybe doing just a quick either fast exam, or whether we want to come up with an abbreviated stroke scale. However we decide as an organization, nursing is going to bring that back to the physicians as to how we want to do that. He mentioned that radiology is now sending the images to our radiologist and to Virginia Mason. They can have them in order in 5 minutes. So from the time the patient gets their CT, and it actually literally goes at the same time it's being pushed both ways. So the neurologist can actually see the CT within 5 minutes. Some of this is, as you can see in the notebooks, is laminated because we'll reuse them. Some are papers that will go into the chart and we will refill every time. We did get the Spanish-based ones so that if we have doctors that can speak Spanish, or nursing that can speak Spanish, and we can either use language line, or if the doc speaks Spanish, then we can use these. We felt that nursing, if they don't speak Spanish, either needs to use the language line, which is very hard to do, but the hospital's not going to pay for a new service. So we're going to have to do the best we can, and we may have to abbreviate the stroke scale a little bit to take out some of this language. Swallow screen, kind of a scripting for nursing and doctors as far as talking to the families. We kind of put it in 8th grade language. The anticoagulants and antiplatelets, the pharmacy has taken ownership to this list. Every time there's a new anticoagulant or new antiplatelet, this list will be updated in both the manufactured trade name and the generic, so that if they're on one of these and we don't, it's just a nice little list. Then that was all kind of nursing driven. In here is also the inclusion-exclusion, which nursing will be handing to the physician. It doesn't matter what physician it is. You have to fill out this inclusion-exclusion. If the patient is a TPA candidate, then they sign a consent. There's controversy over to whether we really have to sign the consent. Because it is an FDA-approved drug, we technically don't have to sign the consent, but KDH at this point has chosen to continue with the consent. And then a TPA dose chart. And one thing for you guys to know is that you don't have to do the dosage. You just say TPA per pharmacy, and that's, I think, how it's written in the order sets. And pharmacy will do the weight and all, that kind of thing. And then there's some patient education, including that chart that he just showed. So one of the things that when we were doing the event, Dr. Bartscher was saying was, if we have the patient to CT, the 3 things they need to know that this guy's going to ask for is their last well-known, their finger stick, and their platelets. And the lab, Debbie in the lab has said that initially now we can change it, our CBC, to the just auto diff, or we can change it to where they don't even have a diff, so that we can get our platelets a lot faster. So we should, by the time the patient gets back from CT, we should be able to get the platelets. And we know the last known well, and if we have a finger stick, those are the 3 big things that they need to know. We don't have to wait for the radiologist to call us back, or even fax it or whatever. If he can read it at 2 in the morning, that type of thing. So when we call a stroke alert overhead, if it's in the ED, the CCU nurse is going to come down, and that nurse will be responsible for doing this checklist. So as we're doing the tasks in the ED, the person from CCU will be doing this checklist. If it's on the inpatient side, the ED nurse will grab the cart, bring it down, and so that we have it on the inpatient side, so that we can use it when the neurologist says that Dr. Kirshner needs to, or she says, I'd like to talk to you face-to-face or whatever. It's going to live on the ED floor, right by the EKG machine, under the tracker by rooms 2 and 3. It'll be plugged in. It's that machine back there. It'll be plugged in. It runs on a 4-hour battery, so it doesn't, when we're using it, it doesn't have to be plugged in. It just needs to be plugged in between.
Sorry, one more time. In the emergency room?
In the emergency room.
2 and 3.
Yes, it's going to live there. It can be used in any, we're going to use it, we have it up here, we have it set up, any place that has a data port. And so all the med-surg, all the CCU, and rooms 1 through 5 are wired for using Telestroke. Initially, what's going to happen is in med-surg and CCU, until they have a new switch they have to get or something down in the basement. Anyway, we're just going to undo the data port for the computer in the room in CCU and med-surg, plug the Telestroke in, and then it'll be ready to go. And I think I know they would like the primary RN. That was kind of our choice, was the primary ED RN or the primary med-surg CCU nurse will be the facilitator helping out with the Telestroke consult. And if it's on the inpatient side, the ED nurse will stay until the dust settles, and then they'll kind of fade back to the ED. And but we're going to leave the Telestroke stuff up there until you're comfortable that the neurologist doesn't need to. And then again, and like he said, the last question is, what else? Any neuro consult you need at this point. But this morning we had a big ICH in the ED. Patient ended up going to Harborview, but you have a patient that shows stroke symptoms like that. I know, we laugh every time. But
That was me, by the way.
they can, and he was here.
I know.
I'm not shaking my head about you guys, I'm shaking my head about
Yeah. So anyway, any neuro consult this can be used for. We want to use it to the best of our ability. Carrie, what else can you say?
I don't have much more to say, except I want to thank everyone for coming, and certainly for the KVH team that helped put this all together, and the work that everybody's done on this and for this. This is really about the patient. This is for all your patients here, and certainly all the patients at BM that we see with stroke symptoms, and that we'd like to take care of as quickly as possible. This afternoon, after you guys are done, and after Dr. Bartscher and I do a little demo, we'll start looking at the nursing staff and trying to make sure that they're up to speed and comfortable with this process, which will be new, but we've hopefully designed the pathway and the process to sort of dovetail in the Telestroke machine into what you guys are normally doing with your stroke patients. So we're trying to eliminate any additional work. There was a question I think Eric asked about whether this process will add length of stay overall numbers to your hospital. And again, that's a variable thing. Most of our stroke teleconsultations are somewhere in the 10 to 20 minute range, say 15 minutes. We had one just recently, however. There was a long, involved process, not so much having to do with the severity of the stroke, but having to do with family. The questions that the family had about whether this was appropriate and how the patient was going to react and those sorts of things. So the neurologist at that time spent probably an hour making phone calls and talking to the family and going over various and sundry aspects of the stroke care for it turned out to be a patient who had just come from a Mariners game. We fortunately had seen her in a very quick time. They walked in and actually got a cab from the Mariners game. So we had that time, but really, as time went on, we were cutting it rather close. So yes, it may add a little length of stay time, but For this took, all this time was involved with the neurologist and not with the ED provider. So my point is that your involvement as the provider will be as much or as little as you can work into it. So the doctor, that particular patient, came in at the end. We always like to loop back as far as the neurologist goes and make sure that everybody's comfortable. If you have some disagreements or some thoughts or some questions about whether this intervention is appropriate in this particular patient or aspect, feel free to loop back with the neurologist via telephone somewhere out of the patient's room so that you can have that discussion. But we're really trying to get, although your participation in any of the Telestroke events is encouraged and it's just fine, but we understand that you'll be busy and that there'll be other things to do. So you may need to leave the room. We're trying to teach nursing staff to do the facilitation process. I think all of the consulting neurologists have learned that there's some variety in training for NIH and for doing some of the neurologic testing that we do. And they're very good about sort of guiding our staff through anything that they'd like to do, finger nose, as far as all the other testing that goes on. So that will happen, and we want to assure the nursing staff that there will, although we'll try to make it as easy for them as possible, that they can certainly count on the docs to sort of tell them what they need and what happens. So again, all about the patients. Thank you all for doing this, and I don't want to take any time away from what we're going to try to do as a demo right now.
We have one more comment. So in follow-up, you saw the portal note that the neurologist writes on their end. We will have, there's 3 people that have been assigned to retrieve, with every patient that we do telestroke with, we will retrieve the neurologist's note and we will scan it into either the inpatient or the ED chart, depending on, so it'll probably be there a day or maybe 2 days later, but we're hoping to check the list every single day, print it out for you so that you have immediate follow-up on what happened to your patient. So whether it goes, the patient goes to Virginia Mason, they stay here, whatever it is, then we're going to have immediate follow-up so that you can know what's, what actually happened.
So are the patients automatically going to Virginia Mason after TPA?
No, that's not the intention. So
How do you decide which ones?
That's historically what you guys have done? Mm-hmm. Yeah, certainly that is a different decision that I think deserves to be made, and you guys deserve to be leading the process on that. So we're here to support you in what's right for the patient and what's right for y'all, and if they're certainly welcome always to come to the meeting.
Yeah, I was questioning why they would go. What would you guys do differently than we would post TPA?
So that's a great question. I think the shortest answer to that is there's 2 things to think about. One is the acute and one is the subacute care, right? So in the acute care, if there is the opportunity for additional intervention, the early in the window and they could still potentially receive intra-arterial intervention, that's something we wouldn't do here, which they would have the option for. If that's not a possibility or that's not in the cards for that patient, then really it's just about having the facility to manage them, and the bigger the stroke, the more you may be concerned about either hemorrhagic conversion or swelling, management of sodium, that kind of thing. So I think the more potentially critical care and complication possibilities are there, the more, in my experience, smaller hospitals will be looking to transfer, and the more simple, clearly it's a small stroke, the vessels are open, they got the TPA, and they feel comfortable with the neurochecks. That's something we want to, and we're committed to helping you build that expertise in the facility if that's something you as an institution want to do, in terms of making sure that you meet the criteria to be yourself, whatever level of stroke center you aim to be, and just getting those neurochecks and the vital signs and all that.
Just remembering back to early days of TPA for MI.
Mm-hmm. That's the one thing that we have to have
kept the patients. And we took care of it, and it didn't seem to be that big of a deal.
Yeah.
is it different for this?
It's different only in that neuro is one of those vital signs that a lot of providers have a very low comfort level with. And so it's really, our organ system needs regular neuro checks to be adequately monitored in the first kind of minutes and hours after injury, and sometimes days. So it's really building your confidence in facility and monitoring that neurological system locally. I mean, we're here to be your partner, so in other spoken hub models, a lot of times a system will start off by transferring all the patients, express an intent and desire to get more experience and keep more of their TPA patients and grow that. And then when there are complications, reach back out. I mean, we're here to continue to consult once the patient goes to the floor and continue to back up their care. And we can even, consider, a more structured model to how we would continue to follow those patients with you remotely, but that's something that we haven't worked out yet.
I think Nora, can you speak to that as the head of the hospital? She could.
I guess we need to just do it case by case. I don't personally have any issues with keeping post-excluded patients. I think the nursing staff needs to also feel comfortable, so I think it's open to future discussion and developing a way to contact back with you.
Yeah, and we can have those conversations with you if that's helpful in terms of maybe think of a general guideline, not strict, case by case as you say, but a general guideline about when you'd be more or less comfortable to help get your feet wet with that and do it safely.
Now, if they bleed, they're that 6% that bleed.
Right.
Are you doing an intervention there that we can't do here?
Only if they bled enough, they would need a neurosurgical intervention, right? Which would be pretty catastrophic for most of these folks. Usually the major medical intervention initially is just cryofibrinogen if cryoprecipitate if the drug is still active, if it's very early on. And other than that, it's really supportive care and attention to if they get into trouble from the swelling and shift and kind of SIDH, sodium management, that kind of stuff. That the majority of people who bleed just have a little tiny bleed, and it may even not even be symptomatic. So it's a minority of patients we're talking about. There's nothing to say we couldn't transfer them at that time if they became a patient that we were no longer comfortable taking care of.
In the unlikely event that a patient presents to our office in the outpatient setting and we feel they're a candidate for TPA, they come in an hour after they're seen, they're doing well. I presume that the best way to initiate this is, honestly, getting them to the ER and then calling you guys, or just is that something, just get them into the ER and allow the ER to do all of that, or ordering the CT from our end in the outpatient setting? Is that?
Well, I think initially what you said in the sense of earlier the better, so I don't see why it wouldn't be okay if you guys at least inform them and then inform us. And this is the lit candidate, and that will help the process for us in the emergency room, because when we get a heads up that the patient's coming in, we can streamline it and get it all going and get the room and get the thing going. If you want to come in and see your patient and assist with it, I have no problem with that either, but it would be very helpful for us if you could start the process.
We could actually order the CT and then from there just send them to the ER send them to the ER after the CT.
And we actually did 2 months ago. We had a family practice doctor drive the patient over in a wheelchair to CT, did the neuro consult from CT, and then ordered an ambulance and the patient never went to the ER. And I'm not saying that's what we want at all, but it can be done because they actually got the neurology consult and the patient, they didn't get TPA, but they actually did go to Virginia Mason from CT with the family practice doc spending a couple hours with that patient in CT. Not what we're saying we want. Or that should ever be policy or procedure, but that did happen.
Sure.
And I only found out about that stroke patient later through Claudia. So,
The problem with us ordering CTs though is the whole non-emergent, emergent CT ordering and pre-approval.
Registration through the hospital, registration.
So they can order it.
Much quicker, yeah.
So I don't see how it would help us to try to order it for them. They might as well.
These emergency pathway patients typically really benefit from a standard process. So you guys have to answer that question yourself. I would say at our institution, if that happened, it would immediately get shunted to the ED and go through the standard ED process, but there would be a call from that PCP, at least to the ED doc,
Sure.
maybe to us, but it may go through the ED doc. I agree with Dr. Frick that, if you have the time in the facility and know how to use the system to page us, I'm happy to talk to you. You're the one that's seen the patient and knows the story firsthand. It's always good to get that firsthand story rather than playing telephone to multiple people, as long as we still loop back to you guys, because they're going to be under your care once they get to the ED. So that's the only slightly tricky thing. That's fine. I also just want to mention about Carrie's story about Zori's patient, that is a big outlier in terms of my experience. I don't think in hundreds of Telestroke consults I've done, never done one that lasted an hour. So I don't want you to get too scared about that. Our docs, our neurologists, also for some of them, this is new. Being a teleneurologist for some of the non-stroke docs, and we put them through some very standardized training, and we're continuing to drill with them on a weekly basis so they get more and more comfort and experience with these cases. And so what we wanted to do is to try to show you at least the technology in action a little bit as a kid. We have 10 minutes until noon. We'll have some pre-scripted little scenarios here. And I think it'd be most fun for everybody if somebody would be willing to play the facilitator. Carrie could be the patient, and then somebody could be the doc who would call. And whoever's the doc, the ED doc who's calling, could just sit in the room and pretend you're calling and give me the story. But then what I can do is pretend that I'm off-site, and then I can show you what it looks like when I log on this computer, and then we can see what the televideo looks like in terms of its quality, the ability to move the camera around, that kind of stuff. If that sounds okay to you, interesting for you, let's certainly do that. The problem is if you put it here, then if we do it here, you can see both sides live and through the camera, but we'll just have to keep the volume on mute, otherwise we'll get a whole bunch of feedback. So you want to try to do it that way?
Whatever you want.
Yeah. Okay. I think it's more powerful when you see it out of the room, because then you really
Well, I can go to the hall.
You want to do it in the hall?
Yeah.
I just need a data port.
Oh, I see. Well, since we only have 7 minutes, then let's do it here.
Okay, so I get the call from the ambulance. Patient was at a barbecue with friends 45 minutes ago. He was trying to talk to his friends. His words were very thick. They had a hard time understanding him. He was able to tell him he was sick to his stomach, and then he puked a whole bunch. He was drilling out the right side of his mouth. His left arm was not working correctly. His friends called 911 because they saw a commercial on TV of signs and symptoms of a stroke. Past medical history is he's had a chole, he has GERD, and he had a right total knee, all in the past. He has no allergies. His blood pressure is 168/80. His finger stick is 163. So the ambulance, and they're 10 minutes out.
That's thorough EMS report right there.
We get good EMS reports, we really do. So they're 10 minutes out. So, yeah. So we're gonna call a stroke alert, because this just happened, and we're gonna say ETA 10 minutes. And when the medics get here, we have a good history, we have a finger stick, we have a blood pressure, we're gonna go straight to CT. You guys are gonna go, maybe even follow him to CT, because the ER's empty. And then you're gonna be the doc, and here he is, this is Carrie.
Yeah, they're definitely going to want to recheck the.
Back from CT.
She's good.
She's the
I'm
facilitator. She's the
facilitator. I
nurse.
make the call,
Linda,
actually.
wouldn't they check on the patient on the way to CT to make sure the symptoms were still there, or no? Would you guys normally check a quick exam, Dr. Frank, or not?
What was that?
If this kind of situation where they called in ahead, would you normally check an exam when they rolled in real quick at least, or would you just wait till they get back from CT?
I would personally, I do a little bit of an exam
Yeah.
prior.
Just CT?
Just lay on the hands, look at them.
Okay.
And it may be in the hall.
Yeah, sure.
You have to do something, just a quickie to know whether they're the same, worse, or better,
Exactly.
rapidly improving by the time they get back.
But then they are still gonna go straight to CT.
Okay, so tell them if they're the same, better, or work rapidly.
He's not getting better.
Okay, so then are you guys gonna call, or are you gonna wait till the patient gets back from CT?
No,
before you
we're gonna call right away.
So somebody's gonna call me,
No, I'm gonna look at the scan first.
You're gonna look at the scan first?
Yeah, and it only takes 5 minutes, but I'm not gonna call before I look at the scan.
Okay.
Okay. And in the meantime, this poor guy is getting on our monitor. We probably wouldn't repeat a finger stick, but they had blood drawn and it's already in the lab. And 5 minutes later, he's been in CT, so his platelets are normal. His finger stick was 163 and he was only 45 minutes out.
So Dr. Frick will make a telephone call to the neurologist on call, and then you'll decide if a telestroke call is warranted.
Right, so how'd that go? You guys would either have waited or not waited for the CT, right? So you'd call me and you'd tell me that same story, basically, right?
Yeah.
So I come to you and I say, I'm your nurse, do you want me to initiate the telestroke call?
Wait 1 second, right, because we have to finish talking.
Oh, I thought you were
He's on the
done.
phone with her, so.
I didn't know I was doing this, so,
It doesn't have to be you, but we can nominate you.
all right, so it's just, yet again, it's the 52-year-old John Johnson that comes in 5 minutes ago, time of arrival, barbecue. Is that what you're saying?
Okay, whatever you think I need to know for you would tell me.
All right, so this came into the emergency room. A lot of times what we would do is tertiary look at this patient, make sure they're stable, make sure we have an airway, make sure we have a blood pressure, sugar, all that kind of stuff. At that point, they would go straight to the CT with the paramedics on board. Initial call would be going to Virginia Mason in the sense, possible lytic candidate, especially if this patient is in the time frame. A lot of times we'll get the CT back, we'll tertiary to look at it, give you the call. And then at this point, I would ask the nurse, who's bedside, obviously we need to get an IV, we need to get the stroke scale going, and we need to get a history of family members of, onset. Is it a true onset? Was the time frame truly 45 minutes ago, or was it 2 days ago? We also noticed something else. And so that's how I would initiate it. And then I would start, if I get the CAT scan result back, which is usually I think 17 minutes is the time frame we're getting from our radiologist, then I would continue to initiate the call back. Sometimes it takes a little time to get a hold of you guys, and then go from there. We then, at that point, have an initial NH stroke scale, hopefully from the nurse, have an IV established, have the blood going down to the lab, and then go from there with the conversation to you.
Okay, so I would call you back at some point in that process, and then I would say to you, I would exactly say those same things. What was the finger stick, what's the blood pressure? Do you know the time lasting well for sure, or is it just reported to you by AMS? And based on those things, we'd probably agree for this case that telestroke would be warranted, right?
Sure.
And so it would be a quick call, like 30 seconds, and we'd say, okay, see you on the other end, boom. And then I'd basically go over to my computer and just power it up while you guys were getting back from CT and everything. And what I would do is, I would probably just go ahead and join the room right away, like this. And then it might be the case that you aren't back, and so I just might set up the camera like this so that it's in a good position for me, and then I might be able to, can you guys see me on that screen over there?
It cuts off your eyes.
Your head's a little low.
Yeah, sorry, 'cause I'm not.
There you go.
in a good position.
Okay, that's good.
I can view myself as well.
Don't hit your head, please.
In the meantime,
I might mute my camera like this so that I'm just not available. If you guys weren't back in the room, then I would pull up my other applications. Okay, go ahead, Dr. Frick.
in the meantime, we continue with this NH stroke scale. We would confirm the medication list, because obviously it comes back around Coumadin. Surgeries, we get the inclusion and exclusion criteria out, kind of go over the whole process. At this point, I would start, if this patient was a lytic candidate, I would start talking about lytics, what lytics are about, and what all those kind of things. And then with this, I would punt it to the specialist to do their exam.
So say I had a little more time before you're back in, just so I can show you what I'd be doing. I'd be pulling up this documentation system. I'd be choosing Editas as a spoke and starting the console. just left me out because I've been inactive.
And then she's going to be explaining the telestroke to the patient.
So I'll say, have you ever used Skype or talked to someone over the internet? Oh, you're drooling. We will be doing something like that today. So we're going to use a computer and a video camera to talk with a neurologist from Virginia Mason. A neurologist is a brain specialist. You don't need to worry about what to say. I'll be here to talk with you and the doctor and make sure we all understand each other. And because we can do this, we can start planning for your care right away. Dr. Frick was talking to you about TPA and that might help you, and we're worried you might be having a stroke. Okay, so we have the computer all set up, so let's see if the neurologist is ready to talk. He is going to want to talk with you and examine you, but he might have me do some of the things so that he can see how you perform.
Okay.
Okay.
So I'm starting to hear that they're there, so I'm going to go back and introduce myself. Hello, this is Dr. Bartscher from Virginia Mason. I'm a stroke neurologist. Can you hear me?
You're not on the screen over there.
Okay. So you should tell me that.
We can hear you, but we can't see you.
Good. So I'm going to try again. Can you see me now?
Yeah.
Very good. And could you introduce yourself, please?
I'm Nurse Powers. This is the patient, Mr. Stevenson.
Thank you, Nurse Powers. And Mr. Stevenson, my name is Dr. Bartscher. I understand you have some new symptoms. Can you tell me what happened?
I was at a barbecue.
He was at a barbecue.
Yeah, I heard that. Very good. And what happened to you, sir?
I got sick and dizzy, and I can't hear.
About what time was this?
About an hour ago.
About an hour ago, okay. And so what we want to do now is check your exam. We're going to do a neurological exam together. Right, so Nurse Powers, I'm going to ask you to help me on a few of these components.
Okay.
And we're going to fold in your CAT scan results and talk about the possibility of treating you for a stroke, if that's what we think you're having, okay? Which Nurse Powers may have explained to you already. Do you have any questions before we get started?
No.
Okay, I want you to do a few things for me, okay? I want you to open your eyes, close your eyes. Good. Open them again. Look to the right side. You can see it for those of you looking on the screen. I can zoom in quite a bit, so I can see his eyes pretty well. And then I want you to smile for me and stick out your tongue. Good. And now, can you try to squeeze Nurse Powers' hand for me? And then let it go. Good. Okay, can you tell me the month, sir?
It's November.
Okay, and how old are you?
63.
63, okay. I want you to now lift up your arms. Can you see me? I want you to lift your arms up like this. Try to keep them up for 10 seconds. Ready? 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good. And relax. And we're going to try the legs one at a time. Can you lift up the right leg for 5? Try to keep it up there. 5, 4, 3, 2, 1. Good. And the other side, please. Ready? 5, 4, 3, 2, 1. Good. Okay. Nurse Powers, do you have a pin, a safety pin? Pretend you do.
Yes.
Could you touch him on the right arm and then on the left arm? And I want you to close your eyes, sir, and tell me if you feel her touching you. Yes or no?
Yes.
Okay. I'm going to try the other side.
Yes.
Does it feel the same on both sides?
No.
Okay. Which side is different?
That's what I
Very good. And now can you, Nurse Powers, do this for me. Touch him either on the left or on the right or both at the same time and mix those around.
On the right or left arm?
Left, right, or both. Can you do the arm to start? That's fine. And then I want you to tell her where. You could stand over him and place your arms on either side so he can't get cues from how you're moving. That would be perfect. Good. Now tell us where she's touching you, left, right, or both. Ready?
Both.
Good. Now?
Yes.
I want you to prompt him every time you touch him, Miss Powers.
Okay, I'm going to touch you now. Which side?
Both.
Which side?
Right.
Which side?
Left.
Do you want me to keep going?
Can you tell me, is he getting it right? I can't see your left hand, so you'll have to report to me.
Yes, you got it right, all 3
Okay.
times.
Let's do a variation where you stand right above him, just like you were with your hands to either side of his face like this, okay? And, sir, I want you to open your eyes and look right at her nose. I want you to stand right in front of him like this.
Okay.
With your nose closer, a little closer. You're doing great, good. Stand, so they're kind of at the corners of your vision and his, right in between you, good. Look at her nose, and I want you to either move your left hand, your right hand, or both. And I want you to tell me where you see her hands moving, okay? Got it? Keep your eyes on her nose.
Where do you hear my, or where do you see my hand moving?
Left.
Okay, where do you see my hand moving now?
Left.
And how about now?
Right.
How about now?
I have some double vision, I think. It's hard to see.
Okay, how about now?
Left.
Okay. How about now?
Left.
Let's try this one more time. How about now?
Right.
And now?
Right.
Is there anything else you want me to do, or is that enough?
No, can you tell me how he did there? I was just,
When I was doing his right upper eye, he said he had double vision, but then he got it right the second time.
okay, perfect. We'll kind of circle back and test that a little bit more if we have time. I'm going to break now from the scenario, just to say, this is to give you a sense of how this would go. For those of you who are watching my screen, you saw that I flipped back to start to document the stroke scale, and you'll see that this documentation tool will also have an automatic calculation here at the bottom that will count it up for me as I'm documenting it. It has a lot of other things in the decision support, including a full contraindications checklist. It'll allow to calculate the dose of the TPA for me at the end and so forth. But really, I want to prioritize the exam and taking care of the patient just as if I was in the room. And this is there to support me. If I can use it real time, great, especially if I'm at a desktop with big screens. If I'm on this little laptop, I'm going to mainly be focusing on my clinical exam initially, and then going from there. The other thing that I pulled up is the scan, and if I hadn't had a chance to look before, I'd be looking at this as well. This is small, but I can also make this larger so I can look for cell signs, and I can window this appropriately.
The lytics usually work that quickly, as we just saw here.
But the point is that this is a good candidate if it looks great, right? So if it looks normal, that's a good sign. Of course, we're concerned because of his story about the posterior circulation, where CAT scan is notoriously insensitive to showing early signs of stroke. But so those are the 3 tools that I'm using simultaneously. Can you talk about your experience as a facilitator?
It was maybe hard for me because I'm not used to doing the NIH stroke scale, and I had to describe my findings back to you.
Yeah, so one of the things that I could have done better is I could have asked you maybe to stand on the other side of the bed or to move the cart so that I could have seen a little bit better what you were doing as you were doing it.
Yeah.
I wouldn't need you to report as much to me. So that's something that I can do a little bit better as the examiner. That we have the ability to do. Good. What was your experience as a patient, Terry?
It was fine. It was, I guess, as far as how you appear on the monitor here, a little bit more of you would be great, a little bit more face. And secondly, it's nice to, I think, as the patient, to be able to connect with somebody that I might see, say, tomorrow or later today, depending on the time, as far as the neurologist, that if there was going to be a transfer, then I would at least have a connection with somebody at the other institution.
It's also a warm handoff. That's the new buzzword, all that
And so we would follow this with a conversation about risks and benefits, unless it had already been had by Dr. Frick while we were waiting to connect, in which case it would just basically confirm. A lot of times, maybe by the time we connect, especially if you're waiting for the CAT scan in the interim before you call, you may have already gone through that whole checklist, and you can tell me right at the beginning, we go through the TPA 1 contraindication, yes, no, and then I can just basically confirm that one. It's going to be a great case. And the other thing, at the stroke neurologist's discretion, if it's quite obvious from the very beginning that the patient has a full syndrome, and I'm seeing the CAT scan that has no blood, I may just start the stroke scale, and this is just stylistically, but I'm telling you this is one of my approaches sometimes as a stroke neurologist, thinking about time as brain. I might just start the stroke scale, confirm that there's aphasia and no movement on the right side. I see a big hyperdense left MCA on the CT with no bleeding and no early signs. And I'll stop the exam momentarily and say, sir, you're having a big stroke, you're a candidate, and I'll make sure the pharmacy's mixing the TPA, get that done first, so you can get the bolus and get the drip started as soon as possible, and then circle back and finish the NIHSS. And one of the things that's nice for us for transfers, just to close, from the physician's standpoint, is if I see this guy and I examine him myself, and then he shows up in a different situation when he gets to the other side of the mountains, it's a different level of confidence that he's changed if I've seen him myself and examined him myself, just as you would have if you had seen and examined the patient, and you're not comparing it to someone else's report. So that's another, I think, really nice thing, especially if you're thinking about intra-arterial intervention or worried about complications. Okay. Good. I want to be respectful of time because we're already 15 minutes over. You can do as much or as little more as is helpful for you guys, but tell me what questions.
So so it's a bolus and a drip for how long?
1 hour. The bolus is 0.9 mg per kg up to
Sleep fast.
the ceiling, and then